Good afternoon and welcome everyone to our webinar, Skilled versus Teachable, Maximize Outcomes, Decrease Denial Risk, and Stay Top of License. This webinar is sponsored by Aegis Therapies. My name is Jacqueline Warschauer, and I work in the Compliance Department as the National Director of Medical Review and Quality Services. I'm a PT, and prior to coming to Aegis Therapies, I was a medical reviewer for Medicare. I'll be presenting today with Mary Saylor, who is also a PT and works in the Aegis Compliance Department as the Medical Review and Denials Manager. Please note that you have all entered this webinar in listen-only mode, which means that your microphones were automatically muted. Available in the GoToWebinar control panel are the webinar brochure and slide deck handout under the Handouts tab. If you have questions, and we hope you do, you may ask them at any time during the presentation via the questions feature in the GoToWebinar control panel, which is probably located in the top right-hand corner of your screen. We will attempt to answer all questions at the end of the presentation. If you are sharing your screen with a participant who did not register for this webinar and who wants to receive the CE credit, please share their name and email in the questions feature. For those wanting ASHA continuing education credit, there's an ASHA participant form in the attachments. Please return the form to Shyla Hamrick. Her email is in the slide deck handout. And if you want AOTA CE credit, we'll send you a 2-question quiz tomorrow, and it must be returned within a week to receive credit. Attendance certificates from Aegis will be emailed within 1 to 2 weeks. I won't read this disclaimer to you, but what it's essentially telling you is that we believe, to the best of our knowledge, that the information we will be sharing is accurate as of this moment today, November 15th, 2023. We cannot promise that it will be accurate anytime thereafter and encourage you to stay current with information and updates provided by CMS, their Medicare contractors, commercial payers, and state and national organizations on this topic. This slide shows our anticipated learner outcomes, which are available to you in the slide deck handout, so I won't take up my time reading through them here. So let's start out by taking just a few moments to take a look at the current medical review landscape. Therapy continues to be on most payers' radar. All 7 Medicare Administrative Contractors, or MACs, include therapy services as a focus of their audits. Some MAC TPEs are predominantly therapy. For example, First Coast, one of the 7 Medicare MACs, has 5 TPEs posted for facility-based providers, and 4 out of 5 involve therapy, including Part B therapy, skilled nursing facility Part A, inpatient rehab facilities, and wound care. In early May, CMS announced that it has required every MAC to conduct a 5-claim probe and educate review on every skilled nursing facility, or SNF. They're going to be looking at the medical necessity of the SNF stay. And if therapy is the one skilling the stay, they will be focusing on the therapy documentation. The CMS Supplemental Medical Review Contractor, or SMRC, reports current audit projects including inpatient rehab facilities, or IRFs, and SNF Part A services. Mary and I are part of a denials and appeals consortium with many of our competitors, and some have mentioned that the SMRC over the past month has been sending out very large volume medical record requests, like many dozens at a time, to SNF providers. The CMS Recovery Auditor, more affectionately known as the RAC, lists approved auditing topics, including SNF, IRF, and home health medical necessity reviews. They're also automatically editing for therapy untimed service codes that are billed with multiple units. As you know, service-based codes are to be billed as 1 unit per day. And finally, they are looking for Part B therapy claims that overlap with an inpatient hospital or SNF stay, or overlap with a home health episode of care. This is because inpatient stays and home health episodes of care are all paid as a bundled system. Any therapy provided is the responsibility of the provider or agency, and payment is included in the bundled payment. So, when therapy is a focus of the review, what's the most common therapy denial? And I say that this is not just an aegis thing. This is across all of therapy. Because remember, I used to work for Medicare. What the most common therapy denial is lack of documentation that supports that the skills of a therapist were needed. What criteria must be met in order to classify therapy as skilled? It's a big question for today's session. Where better to look than building the foundation for this concept of skilled services or therapist skill than to CMS? This slide contains content that was borrowed directly from CMS's Medicare Benefit Policy Manual. Now, I'm not going to read every bullet word for word to you, but there are common buzzwords or phrases often used when discussing skill. And you'll see these incorporated in the statements here. Things like complexity and sophistication, requiring the judgment, knowledge, and skills of a therapist, necessary for improvement, maintenance, or prevention of decline, medical necessity, assessment, analysis, instruction, descriptions of change. These concepts will be discussed further during this hour that we have together. So just know, as we do speak about them in the upcoming slides, that the reason we're addressing them is that CMS has established their level of importance for us, and many payers follow the Medicare coverage guidelines for therapy. I'm guessing that those buzzwords and phrases were all pretty familiar. So if a service is complex and sophisticated, it requires my training and expertise as a licensed therapist, and it's medically necessary to improve, maintain, or prevent decline, then it's skilled. Perfect. Easy. We can just wrap things up right now. But is it really that easy? Despite the deceptively simplistic outward appearance of skill, it's remarkably hard to put your finger on it. It's equally challenging to document it well, since most of our denials from medically reviewed charts are related to the perception of skill in the medical record, or more appropriately, the perceived lack of skill. First, there's no defined list of skilled tasks. Like, wouldn't that make our life so much easier? I did Therex today, and look, Therex is on the skilled list. So I'm good to go, right? If only it was that simple. Most activities aren't black or white, but instead they live somewhere in that middle, in that gray space. Sometimes they're skilled, but also sometimes they're teachable for a home program or an assistive restorative program or functional maintenance program. It just depends on the circumstances. ADLs, safe swallowing, ambulation, Therex, these are all things that require our skill when we are training a component of those tasks, when we're modifying a previously used technique, when we're introducing something new and analyzing the patient's performance. But there are also many circumstances in which patients we treat can perform ADLs, swallow safely, ambulate, and exercise without our assistance and guidance. Many of these tasks require our skills as therapists at the outset of the episode of care, but the need for our skill diminishes over time as the patient improves. Skill isn't defined by the task, but rather by the complexity of either the task or the patient's clinical presentation that necessitates our unique knowledge, skills, and abilities as therapists. I suspect that some therapists' frustration stems from the variance between what is written and what actually occurred. When a therapist receives a documentation audit or an insurance denial that questions the need for their skill, it's easy to feel frustrated, maybe even angry, likely because that therapist immediately starts thinking about all that skill that was required and utilized every day with that patient. Therapists might respond by thinking or even saying, "How dare they think that about my services?" Well, the answer is that the documentation auditor or medical reviewer can only go by what is written, and the content of the written note doesn't always project the same picture as the one that exists in the therapist's memory. Lastly, we as therapists tend to be super patient focused, right? Our emphasis is on what that patient can do, what they can't do, how much help they need, how much progress we believe they can reasonably achieve, and what do they want to accomplish from this rehab. We focus so much on the patient that we forget to also look inward and document the details of what we, the therapists, contributed to the interventions. How were we using our hands? What were we thinking? What were we analyzing? What were we planning? These details are the ones that speak to skill, and they are just as important as the patient-centered details that speak to medical necessity. The skill comes from you, the highly trained therapist, and what you are doing and thinking during the treatment. This is just a list of potential skilled action words that can facilitate quality documentation. However, note that these words alone won't make it skilled. These terms alone, like analyzed or progressed, won't convince anyone that the service was skilled. Context is needed to describe the details of the action. For example, if the speech daily note reports, "Analyze modified soft diet," the note must go on to describe the results of that diet analysis and the treatment implications. The action terms used must be relevant to the patient and the current treatment. If we repeat the same action word, like initiated, for example, and keep talking about the same initiated thing over and over again for days on end, does that still carry the same weight? Probably not. It has to make sense. It has to be appropriate given the context of the situation. Remember also, what is skilled today may not be skilled tomorrow. These action words we just talked about will get us started, but it will be the patient and point in time specific details that will drive the concept of skill home to the future readers of our documentation. A huge part of determining if something is skilled is to look at all the details of the situation. Again, skill is not task specific, it's situation specific. That's why it can feel a bit like a moving target. Hopefully, with this next bit of information, we can stabilize that target back into your sights. While discussing skill last year, our medical review and denials team had a bit of an epiphany. The clarity we're seeking lies in a handful of those buzzwords: assess, develop, analyze, and modify progress. If each of those elements are present in an intervention, it's skilled. This isn't new conceptually, of course. We've just never drilled down in this way before to realize that these are the four cornerstones of skill. So if you're wondering if your services are still meeting skilled criteria, ask yourself these four questions. Are my skills as a therapist required to safely assess the patient's underlying impairments and functional deficits, develop a patient and point-in-time specific treatment plan for medically necessary services, analyze performance during interventions, modify and/or progress the interventions in response to the analysis? If you answer yes to all four questions, the service is skilled. But the next step would be to make sure that those components were clearly documented in the medical record. This slide lists some criteria that therapists often allow to cloud their vision and sway their skill determination. Each of these circumstances are quite prevalent, but it's important we remind ourselves that these do not contribute to our decision about skill. If the patient and/or their caregiver has a history of noncompliance, or if we have concerns that they will not comply with a soon-to-be established program, this would not give us cause to continue to deliver the service after it is no longer skilled. It often comes up that the caregivers are too busy to carry out a restorative program. The facility staff just doesn't have time. Or the patient lives alone without someone immediately available to help them with their program. Unfortunately, CMS specifically addresses this in the Medicare Benefit Policy Manual and states, just as I mentioned for the first bullet, the unavailability of a caregiver will not make an otherwise unskilled service skilled. So I'm going to say that again. The unavailability of a caregiver will not make an otherwise unskilled service skilled. Some patients just prefer to work with us. And sometimes, as you know, not just prefer, sometimes they will only work with us. And honestly, over the years, I've gotten attached to more than a few patients that I really didn't want to transition to someone else's care. But unfortunately, patient or caregiver preferences gets no consideration when determining if a service is skilled. If you can't answer all 4 of those questions from the previous slide with a yes, it no longer requires your skills as a therapist. Lastly, let's talk about diagnosis. While the patient's diagnosis may contribute to their complexity and may impact their need for our skill, the diagnosis in and of itself does not justify skill. Sadly, we see plenty of progressive and debilitating diseases in our patients' medical histories. But remember that it is never the diagnosis that requires our skills. It will only ever be the complexity of the associated underlying impairments and functional deficits of the patient related to their diagnoses, and the complexity and sophistication of our interventions that will require our skill. So I'm going to pass it off to Mary to continue.
All right, thanks, Jacqueline. So keeping those cornerstones of skill that Jacqueline just discussed in mind, let's look at this example together. We have 2 versions of therapy documentation here on this slide. I'm gonna pick on PT for a moment because I'm also a PT, and there was a time in my career when this slide would have definitely applied to me in my documentation. The documentation listed on the left represents the type of notations that we often see in medical records. Patient ambulated 50 feet with a wheeled walker and minimal assistance and verbal cues for foot clearance. These aren't bad details to document because they do give a picture of what the patient can do. However, it does not at all describe the components of skill that existed in the treatment. This type of documentation looks no different than what an aide could possibly report in a nursing home in their documentation. It's beneficial to remember that reviewers will read therapy documentation and will compare what was provided by the therapist to what an aide could potentially have done. If it looks like an aide could provide that service, it won't be considered skilled. So take a moment now and think about the verbal cues for foot clearance that were documented. Does that require the skills of a PT or a PTA? Could an aide say, "Big steps, Ethel, keep it going"? Could that aide provide min assist? Yeah, they certainly could and do both of those things all the time. The documentation at the right, on the other hand, reflects the skilled components of the treatment by documenting more detail about the therapist's actions during the intervention and their contributions to the treatment. Now, these are things that an aide would not know how to do. Stabilizing the hips during a specific phase of gait, timing and grading verbal cues needed for foot clearance during another phase of gait, and identifying the limiting factor for the distance walked. But it also reports those patient performance details that we saw on the left. So I think we can all agree this version looks much better, right? Now perhaps you're thinking, sure, the one on the right does look better, but who has time to write that much? And I won't lie, as a compliance department girl, my holiday wish is to see this type of detail on the right all the time in every note. But that aside, I'm not so distanced from direct patient care that I've forgotten the demands placed on our time as treating therapists. Perhaps this is more detail than you could feasibly document for every CPT code on every treatment date for every patient that you see. But what if you did this on each CPT code in your treatment plan once a week, alternating that detailed documentation between codes on different days? That would still be an investment in supporting your skill, wouldn't it? What if every day you committed to including one extra detail of skill on each daily note you wrote? And then tomorrow you commit to documenting one different detail of skill for those same patients. Can you imagine the impact that would have on your documentation quality? As someone who has written more appeal letters than I can count, I can't tell you what I would do to receive that commitment from all of our treating therapists and what that would do for our medical review and appeal outcomes if those details were consistently documented. It would be huge, I can promise you that. So whether you're looking at your own documentation or someone else's documentation, ask yourself, could an aide do or document this? Skilled versus teachable is another vexing concept for all of us as therapists. We say that if a service requires the skills that I learned in school and demonstrated in order to get my license, then it must be skilled. But that doesn't always play out because there are plenty of things that we learn to do in school that we can then teach to our patients or their caregivers. So the question is, when is something teachable and when is it not? If you answer yes to all 4 of the required skilled element questions, it would not be a teachable task because it still requires your active presence and participation, your skills. If you answered no to 1 or more of those questions, it's likely that it would be a teachable service. So now if you can picture it, we kind of have a 2-bucket system emerging. We've got teachable services in one bucket versus the skilled services in the other. So this is a question we should be asking ourselves regularly throughout the episode of care for all the interventions we provide. Is this a skilled service or a teachable service? Remember, something may be skilled today and teachable tomorrow, so we have to keep assessing and reassessing throughout our episode of care. So let's just look through those bullets together. Tasks, exercises, techniques that will continue to benefit the patient, but can be safely taught because their performance doesn't require our skill. Again, those should be taught. Back to that adage, if it can be taught, it should be taught. Once the comprehension of the instructions and mastery of the teachable task has been demonstrated, it can and should be transitioned to an independent home exercise program, a supervised program, or to a caregiver-assisted program. After we do that, intermittent assessment of that taught program can and should occur as needed throughout the episode of care to assess continued appropriateness and to make modifications or to progress that program if needed. So when determining if a task is teachable, we really need to remember to always consider the complexity and variability of the task, but also the complexity and variability of the patient's clinical presentation. Effective application of this analysis will enhance our outcomes. Think of the quadruple aim, outsourcing those tasks that no longer require our knowledge, skills, and attention to the patient and/or caregivers will allow us to focus on and emphasize those things that only we can do. This will allow us to work at the top of our license and to be efficient with the time we have with the patient. It's good for the patient, it's good for us, and if we document it well, the medical record will scream skilled services to anyone who reads it. And remember, since skill can originate from the complexity of our service or from the complexity of the patient, we need to review the services we're providing from both perspectives. If you determine through that analysis that something isn't teachable, consider this question: why not? Why isn't it teachable? Answering that question and documenting the details of that answer will likely assist you in explaining why it is skilled. So let's shift gears now toward repetition. If a patient has performed the same exercises under the instruction of their therapist every day this week, was that a skilled service? And honestly, the answer is maybe yes, but maybe no too. We'll find the answer by going back to those 4 cornerstone components of skill. Was the expertise of that therapist required to safely assess the patient, develop the plan, analyze the patient's performance, and modify or progress the interventions? If we can answer yes to all 4 questions, then yes, it was a skilled service. If no, then that repetitive task or exercise should be taught to someone else so they can do it in that therapist's place. Yet again, we find ourselves firmly planted in the gray. Repetition we know is a red flag, and it could be an indicator of lack of skill, but then again, it isn't always a bad thing. So how do we decide when it's probably not skilled and when it probably is skilled? The presence of probably is needed here because these aren't surface level decisions. They need to be point in time and patient specific. Remember, skill is situational, not subjective. We already heard that from Jacqueline's portion. The full picture of the patient's deficits, challenges, medical complexity, and needed services must be considered before we can arrive at a decision between skilled and teachable. In the probably not skilled bucket, we see repetition by design. So think of that patient doing pendulum exercises for 4 weeks post-op. Based on the post-op protocol, no matter how good the patient feels and how quickly they master those pendulum exercises, we will not be modifying that exercise program or progressing to more challenging tasks. 4 weeks of this repetitive exercise would most likely not include those 4 required elements of skill. Even if the task is complex at first, if it requires no ongoing analysis, it would also probably not be skilled. So think about safe swallowing strategies. Initially, when a chin tuck is introduced, among other strategies, I would imagine that the SLP is assessing the patient's ability to use those strategies. How much of a chin tuck is needed to achieve the desired results? Is the chin tuck successful in safely directing the food or drink into the esophagus? If over time the patient just needs a prompt to complete that chin tuck and any other strategies used, but can successfully execute it consistently once they're cued, then that ongoing analysis is no longer needed and the task is probably no longer skilled. Going back to those components that cloud our vision that Jacqueline spoke about, non-compliance, unavailability of a helper, or patient caregiver preference, those also would not qualify an unskilled repetitive task as skilled. Now, on the other side of the slide, we have repetition that would most likely still qualify as being skilled. Consider a repetitive task that is still being taught to the patient and caregiver, maybe lymphedema wrapping, for example. The therapist might not be changing the wrapping approach, but it will probably take multiple sessions to teach the technique appropriately. The caregiver has many components to learn: the order of the different sized bandages, the direction of the bandage wrap, the degree of stretch applied during each wrap around the limb. The teaching of the technique with a short duration of repetition, if clearly documented, would likely qualify the service as skilled. Maybe the technique isn't changing, but the patient is at such a level of complexity that analysis of their condition and their response to the repetitive task makes it skilled and something that only the therapist can do. In the last example, sometimes the treatment concept is repetitive, say range of motion, for example, but the performance of the treatment is not. Consider a patient that needs passive range of motion several times a week. The joints and the direction of movement, those probably won't change, but the degree of movement, the force applied during the end range stretch, or the duration of the stretch, or the manual techniques that are used from day to day, all of those may change based on the patient's presentation or tolerance. The analysis that leads the therapist to decide how to address each of those components, if clearly documented, would probably qualify the service as a skilled intervention in spite of that repetition of the range of motion component. Be sensitive to how your documentation will read to an outsider, and remember that variance that exists between what the therapist knows or is picturing in their head versus what's written in the medical record. If you're doing categorically similar things, balance training, cognitive training, but each day you're reassessing, you're making adjustments, progressing as able, make sure that you're documenting those not so obvious considerations, observations, analysis, and modification details. If you had a planned progression, but then assessed the patient and determined that they weren't quite ready for that progression, document that. Without that detail, it would look like you abandoned your documented plan to progress them. If you attempted to progress something, but the patient wasn't successful with the task, document that. It's still evidence of analysis and adjustments, even if the final decision was that the patient wasn't quite ready. If education is taking longer than usual, but the potential to learn still exists, explain that part. What makes this situation unusual, and why do you believe it's still an appropriate element to teach? Those are the kind of details that should be in your documentation. Consider also the optics of the note as you've written it. If the note says that the patient performed lower body dressing and tolerated a pureed diet at lunch, does that sound to you like a skilled person was intervening during those tasks? Or does that sound like something an aide could do with the patient or a family member? How does that compare to a note that would say, initiated lower body dressing and trained use of adaptive equipment? Or swallow trials with a pureed diet revealed significant lateral sulcus pocketing with SLP participation needed to assess, ensure, instruct, whatever it may be. Take credit for your skill. When PTs are training gait, we should document the components of that gait training, and we should call it gait training versus just walking or ambulating. When we're advancing something or initiating something entirely new, use that skilled action word and include the descriptive details to justify the inherent skill of that task. We assess, modify, and adapt all the time without even noticing it. It's just second nature to us as therapists. It flows like LMNOP. If someone is demonstrating elevated distractibility and isn't able to attend to the desired task, what might you do? Pull a curtain, close the door, dim a light, mute the TV. While it's second nature to do that, it's still a skilled assessment and adjustment. You identified a problem, decreased attention to task, you assessed the situation for possible causes, and you took action with an environmental adjustment mid-treatment to enhance the benefits of the treatment you were providing. That's skill. Document that and take credit. Think about those LMNOP moments and make sure they make it into your documentation. I'm also a big fan of sentences that incorporate "this means that" kind of details. This is an opportunity to give insight into your analysis and your mental puzzle assembly. An example I've used a lot in the past is parallel bars. So again, I'm a PT. When I read an evaluation written by someone else and I see that the patient stood in the parallel bars on the first day, immediately I think, oh, that was a rough day. That was a really rough day one for this patient. Maybe your therapy gyms are different, but I never used the parallel bars on day one unless I had to. If a patient was in the parallel bars on eval, they were probably super unsteady and unsafe, maybe impulsive. They may have had extreme pain. Maybe they couldn't even push up from the chair and needed to pull up from the bars just to give us the smallest of oomph to help us with our max assist of 2 or max assist of 3 efforts to get them up. And even then, maybe they only got up partially and for a few seconds. I see parallel bars as a PT on eval, and I think complex patient, hard to mobilize. But do we take the time to explain that? Do we write something like the patient was only able to stand in the parallel bars due to X, which means that they, whatever the next details might be? Do we add that color commentary? Because those are important details for the non-therapist medical reviewer who might be reading the chart in the future. And know that they won't intuitively know that unless you tell them, because they don't think like we think. When describing what you're doing in treatment, use patient and point-in-time specific details. Avoid writing high-level, nondescript notes that could apply to just about any patient on your caseload on any day of the week. That type of documentation adds no value in supporting why your unique, highly trained skills are needed. For example, writing progressed balance activities. What does that really mean? I mean, it might be accurate for today's session, but it doesn't explain how this patient today, their balance activities were advanced because of your skilled clinical decision making. Based upon today's analysis of this patient's balance status, just writing progressed balance activities doesn't showcase your skill. Avoid cloning, which can include copying and pasting, but also it includes just repetitive use of sentences or sentence fragments. We've seen examples where repetitive use of the same generic filler type details, even if not cloned in the traditional way of copying and pasting, can still create a scenario that looks just like cloning. Again, take a moment to make your notes specific to your patient that day and that reporting period. There has been increased concern for cloning since the evolution of electronic health records, or EHR. According to the Office of the Inspector General, when doctors, nurses, or other clinicians copy-paste information but fail to update it or ensure accuracy, inaccurate information may enter the patient's medical record and inappropriate charges may be billed to patients and third-party healthcare payers. CMS adds words of caution when describing cloning. They say that this practice involves copying and pasting previously recorded information from a prior note into a new note, and it is a problem in healthcare institutions that is not broadly addressed. For example, features like autofill and auto prompts can facilitate and improve provider documentation, but they can also be misused. The medical record must contain documentation showing the differences and the needs of the patient for each visit or encounter. Simply changing the date on the EHR without reflecting what occurred during the actual visit is not acceptable. Cloning, like many things in our world, comes in different degrees. There's a cloning spectrum from word-for-word copying and pasting on one end of the spectrum to repetitive use of the same sentence fragments on the other end, but they all fall into that same category of cloning. This slide demonstrates word-for-word copying and pasting. These are two different daily notes for the same patient, and the Therex descriptions are identical, right down to the extra space before ankle pumps and the lack of punctuation at the end of the last sentence. So whether the therapist got here by true copy and paste, Control C followed by Control V, or they just manually wrote out the same sentence freehand, or with the assist of EMR starter phrases or sentence builds, it's still identical. It screams cloning, and cloning is never a good thing. It's generally interpreted as either potentially inaccurate documentation, which will lead to denials, or repetitive documentation, which, by the way, also leads to denials. So it really needs to be avoided. On this next slide, you see skilled intervention descriptions from two different progress notes on the same patient. The yellow highlights represent unique details in each of those notes. Anything not highlighted is on both notes. So what do you think about this? Imagine reading similar notes day after day for a full month of review in a records review as a medical reviewer. Might you think it was by and large repetitive services that subsequently lacked therapist skill? If with all of those words on the page, there were only those handful of words that were new and unique from note to note? Even the content in general is lacking. It isn't patient specific or point in time specific. In fact, after reading it, you don't really know all that much about this particular patient because the words on the page are mostly high level and vague. So remember, if any component of our service delivery is teachable, it should be taught. If it's not teachable, we should be documenting the skilled components of the task of the patient or both. And there are just a list of questions there for you to consider in helping you make those decisions. So if you will pardon the repetition, we need to give one last plug to those 4 cornerstones of skill. Make sure that you document your assessment of the patient's underlying impairments and functional deficits, your development of a patient and point-in-time specific treatment plan for medically necessary services, your analysis of patient performance during interventions, and your modifications and/or progressions of the interventions in response to your analysis. The content on this slide was pulled from real Medicare denials. Notice the language used. PT, OT, ST services do not qualify as skilled services, no longer at a level of complexity and sophistication, no longer requires the unique skills and judgment of a licensed professional. Clearly, again, repetition is a red flag for reviewers. So if you have a patient in which repetition is justified, it's imperative that you document that justification so you can avoid a denial like these on this slide. And that means more than just saying that the repetition is justified. Just putting that sentence in, by the way, this is repetitive, but it's justified, doesn't work. And we see that all the time. People will overuse the word skilled, but I said it was skilled Therex and skilled gait training and skilled this and skilled that. Just calling it skilled doesn't make it skilled. We still have to include those details. So in the case of repetition, if it is justified, we need to include those details of what makes it justified. We can't just say it's justified. Remember that you'll need to showcase those specific reasons. So this leads us to, I think we have some questions coming in, but we weren't sure if we were going to get questions. So we wanted to touch on a few questions that come up often. So we will start with the first one. We'll go through some of these, and then we will go to the questions that have been entered in the chat box next.
All right, thank you, Mary. So our first FAQ, can a patient receive both skilled therapy and be on a restorative nursing program at the same time? The answer is yes. Any component of the treatment that no longer requires your skill can become part of a restorative nursing program. This will permit you to focus more on the areas that still require your skill and allows you to work top of license. So when a component of your treatment session no longer requires your skills, you must make a clinical decision. Is that activity no longer necessary to complete? Or would there still be benefit to the patient if they continued that activity? If still beneficial to the patient, then the next step is to determine if the patient can carry it out on their own or if they'll need help. And if they need help, who will help? This process of assessing the components of treatment for your continued skill is not a one and done process. It's an ongoing, repetitive questioning for each element of the treatment plan, asking, is this a skilled service, meeting all 4 cornerstones of skill, or is this a teachable service?
The next question we have is, what if I tried to train multiple caregivers multiple times and they still aren't able to carry out the program correctly? So if you find that the caregivers aren't able to correctly carry out the program, again, you should ask yourself, why isn't this teachable? As we mentioned earlier, answering that question and documenting the details of the answer will likely assist you in explaining why it is skilled. Perhaps the reason why the caregivers can't carry it out is because the patient or the treatment interventions are so complex that it requires your skills to assess, develop, analyze, and modify and progress. Remember that LMNOP phenomenon. It just flows and we don't even realize we're analyzing until we try to teach it to somebody else and we realize that they can't do it. And if the patient doesn't have potential to further improve their function, then perhaps they're appropriate for a skilled maintenance program. Note, however, and this was on a previous slide, but I think it's worth restating, that Medicare's records saying that the unavailability of a competent person to provide a non-skilled service, regardless of the importance of the service to the patient, does not make it a skilled service when a therapist furnishes the service. So simply because there's no one else to do it would not make it skilled.
All right. What's the best way to summarize skilled services on a progress note? Let me start out by saying that progress notes are not glorified daily notes on a different form. On a day that a progress note is due, a daily note is still required to describe the treatment provided on that day. Rather, progress notes are summary reports to describe the services provided during the progress reporting period, to analyze what's working and what's not, and to justify further treatment. The progress reporting period is the period of time since the last progress type note was written, or since the eval, if this is the first progress type note. The progress note documentation must convince anyone reading the medical record that only a therapist has the knowledge, education, and skill to carry out the treatments provided. The skilled services section should highlight the skill provided during the progress reporting period for each of the CPT codes or interventions, focusing on what has been, listen to these words, introduced, modified, adjusted, progressed, newly taught for exercises or activities and strategies for each CPT code or intervention area. In other words, it should highlight what was different this progress reporting period as compared to the last progress reporting period. It should highlight the change. Highlighting the change will support that the treatment is not repetitive and unskilled. If there is intentional repetition, it should explain from a clinical perspective why repetition was required. Be sure that the skill descriptors are patient-specific and reflect the skill that occurred specifically in this progress reporting period.
So we get questions a lot for examples. Can you show me how a note would be written to support what you're describing to me? So on this slide we have, can you give me another example of what you mean by high-end, non-specific documentation and what would make it better? So this example is looking at a balanced treatment note. I see notes like what we have here on the left all the time. So we have neuromuscular reeducation provided, including standing, static, balance challenges. What I'd like to see, though, is something that looks more like what's on the right. The Kansas University Standing Balance Scale rating of 2 out of 5 means that the patient can't perform any ADLs in standing. Progress to standing balance exercises with new adjusted grip on walker. We're using fingertips only right now. Introduce proprioceptive awareness challenge with wide stance and eyes closed. Patient intermittently returning to full grip in response to increased postural sway. Increased therapist readiness needed to ensure patient safety with the task. We've got a reassessment of the balance scale with a quick extra statement about patient impact of that 2 out of 5 rating. Our progression in this state was subtle, but it was still skilled. It also highlights the increased risk of this subtle progression to support why we, therapists, need to be there. In order to make them stronger and more stable, we need to take them to their limits of stability. And taking someone we know to the limits of their stability is a bit of a dicey game and one that not just anyone can play. It requires our skills and our training. And I think that example on the right shows that in greater detail, certainly, than what we have on the left.
All right, thank you, Mary. We are going to open it up and answer some of the questions that have been put into the questions field on your screen in the GoToWebinar. Actually, Shyla, I think you were going to kind of pull up some of those questions and ask them, and Mary and I will just kind of figure out which one of us will answer.
Yeah, absolutely. The first question is, I think one of the biggest questions I often hear is for an assistant. They are often concerned about saying they assessed or analyzed something due to concerns about language and licensure. How would you address these concerns?
Maybe I'll start and Mary, feel free to add in. So assistants can assess in the terms of they can complete like standardized assessments, right? They can assess strength. They can assess, that the patient is progressing and it's time to go to the next more difficult task, right? They can do that kind of assessment. The part that isn't in the scope is more that analysis. So why are they responding or why are they not responding to the intervention? So if it's more of a talking about exactly just what you did, like we advanced this next more difficult level, versus saying consistently or frequently saying why or what's going on or why they're not progressing. Because when you start getting to that, it's better to talk to the therapist, and then you can restate some of the direction. You can restate in your note some of the direction that the therapist may have given you. I don't know if Mary, you want to add anything?
No, I think you covered that one well.
Okay. What happens when the SNF has no restorative staff and is always short of staff?
I can start with that one.
Sure.
We hear that a lot, certainly. I understand that there are staffing challenges everywhere, but again, it comes back to the regulatory language from Medicare, and that's not a valid reason to bill Medicare for skilled therapy services. So I think that that would be an opportunity to share our concerns with the administration of the SNF. I'm not sure how to handle this. Sally needs X, and I can't say that it's medically necessary for an insurance claim, but that doesn't mean that she doesn't need it. And I think that that's a valid conversation to have, because the OBRA requirements are still in place for all of the SNFs. The residents are supposed to be allowed to meet, achieve, maintain their highest practicable level. So when state survey comes around, the annual state survey or an impromptu visit from the state, they're still going to be looking for those quality of care issues and making sure that the facility is providing that standard of care that is expected at every SNF across the country. So it is a real concern, and I don't minimize that. But unfortunately, the easy button can't be therapy. Therapy billed to Medicare as a medically necessary skilled service when it really could have and should have been taught to a non-therapist, an unskilled caregiver. Jacqueline, do you have anything to add on that one?
No, that was good. Thank you, Mary.
Okay.
Mm-hmm.
Julie asks, she says, I still just don't get how we can take real time to do this documentation when we have 15 notes to write a day and must be productive. Sometimes I'm given 20 minutes to treat a patient. I just can't justify spending 5 to 10 minutes writing their note with them. They need every minute they can get at this point. So how do we truly do this in the time given?
I can go again on that.
Go ahead, Mary.
Sorry. I was just going to say, and Jacqueline, you can certainly chime in, but I understand those challenges. I think the key is to find those moments, seize those moments, those opportunities, avoid those high level details. What detail you do include, make it matter. And if truly you're struggling to find time to do a long-winded note, I certainly get that, but really be specific in what you are choosing to include to make sure that it is patient specific and point in time specific, and try to be cognizant of what you documented yesterday and the day before, and cover something new today, so that when all the pieces of that medical record puzzle are put together, we still in the end have a really good picture of all of those components.
That's great.
I really have nothing else to add, so we can go to the next question.
All right. Having difficulty with discharging people from skilled maintenance when there is no RA or available CNA staff available when the patient is unable to carry certain programs. Do you have any suggestions to help with what would be the next step in the continuum of care?
I think we answered that previously about someone asked, if there's no restorative program at the facility. So again, it may be something that has to be brought up with administration. We can't, right, by regulation, continue to see a patient if they don't need us, right? So then we have to work with the facility staff, with family, whoever, to try to figure out who can continue to help this patient, who can we train? Because there are, as Mary alluded to, there are regulations that say that we are tasked, the SNF is required to have keep the patient at their highest practicable level. So we've got to, and we have to give them services if that's what's needed to keep them there. So, just for good quality of care, again, maybe something you have to bring up with the facility staff.
Okay. We have a lot of people signed a waiver for a recommended diet. Would they be considered non-compliant?
I wouldn't consider that non-compliant. If we were staying with that same kind of patient, if it was a speech patient and we were encouraging them to try strategies to improve upon some deficit area and they were refusing to do that, that's non-compliance. Their decision to eat an alternate diet would not necessarily be non-compliance. I think we need to document it because there are inherent risks to them eating a diet that's not recommended. And certainly from a liability standpoint, if we are working with them, still trying to make them safe on an advanced diet, we would want to make note of the fact that they're consuming textures that are not recommended for them. but I personally would not see that as non-compliant. I would just want to make sure that we're documenting that they have signed that waiver and they are receiving that alternate diet outside of therapy.
Okay, thanks, guys. There are not any more questions at this time. If there's any more, you can put them in the questions box at this time. Just as a reminder, if you are wanting ASHA credit, the bubble sheet is located in the handouts section, and you can download that, fill it out, and send it to my email. It's shyla.hamrick@aegistherapies.com. If you're an OT, there will be a quiz sent to the email that you registered in that needs to be completed within 1 week, and your certificate will be sent within 2 weeks.
I'm seeing questions, Shyla, about the handouts, that people are having difficulty finding those. So can you just give a quick reminder of where to get those downloadable handouts?
Sure. In the handouts section, you should have a panel come up whenever you logged in to the GoTo webinar. It should be around your questions box. The same place, there's a chat feature, a handout section, where the dashboard is.
This is Jacqueline, and maybe because I'm in presenter mode, I am not, on mine at least, seeing a handout. But again, it could be because I'm a presenter and I came in differently. A handout option next to like questions and chat and
I
all
am
of that.
seeing it.
You are? Okay.
Yeah, under polls and above chat, I have handouts. And when I click on the arrow that's pointing toward the H in handouts, then it opens up a larger window and I can see all 3 PDFs.
Yeah, and if you have any problems, can't find them for whatever reason, you can feel free to email me and I will get them to you.
Or email me, Jacqueline or Mary. Our emails are showing on the screen right now. So that might even be easier. And Mary and I are both willing, if you have some questions that come up after you didn't think of them now, or we run out of time or whatever, feel free to email either of us anytime. We love to answer questions because we both are kind of, well, we both are documentation nerds, and I can
Yes.
talk about documentation all day, just gonna say.
And I'm seeing questions about PT-CEUs.
Okay, PT-CEUs, they are the approvals are in the brochure, which is in the handout section. We have approvals from California and Florida, with Minnesota pending. Those are the only states that we have at this point. Most states will accept other state approvals, but you would just have to know your specific state's requirements for that.
And after the handout questions, will we receive our certificate by email?
Yes, yes, you will receive your certificate by email within 2 weeks.
And what will be the name or title of the email for us to take the quiz? Do you know what that might look like, Shyla? How you might label that?
It'll be a Survey Monkey that's
Okay.
okay.
I think we've kind of leveled out here.
I think so. So really appreciate everyone hopping on today. Hope you learned something new.
Okay.
And real quick, Sylvia, or no, maybe that was Kayla. It's scrolling too quickly for me. It'll be the same for PTA. It'll follow State Practice Act, CEU requirements. So it would be the same for PT and PTA.
All right, guys. Well, I think that wraps it up. We are just at the top of the hour and right on time. So thanks for joining, and we will see you guys next month.
Thanks,
Thank
everyone.
you. Bye-bye.